My name's Geraldine MacDonald, and I have the pleasure of chairing this webinar this afternoon. It's the next in a series of webinars that the School for Social Care Research are organising. And we're a few minutes after the start time, so I'm not going to do any more now, except to introduce our speakers, other than to say, if you have any questions and you're able to, please pop them in the chat. And I'll try and keep an eye on them along with one of my colleagues. And at the end of the presentation, if there are some common themes or particular issues, we'll put those to the speakers in the interest of saving time. But if you've not managed to put something in the chat and you have a burning question, there'll also be some time to take that. So hoping I've not forgotten to say anything, at least we don't have any fire and safety regulations to rehearse. Could I introduce Kritika Samsi, who's going to talk about investigating optimal time, perspectives on the timing of moving into residential care. Kritika.
Yes. Hello, I'm Kritika Samsi, and I'm going to talk to you today about a study that we completed last year, looking at multiple perspectives on the timing of moving into care homes for people living with dementia. It's only a 20-minute presentation, so I'm going to just give you a really brief overview of the study and focus on specific participant groups. But at the end, I hope to give you links to all of the reports that you can access, and as well as the publications our research team has produced. I'm a research fellow at the Health and Social Care Workforce Research Unit, and the research team was myself, Jill Manthorpe, and Laura Cole. I just want to start with the thanking all the participants who gave us their time in this research and sharing their views and experiences, and to also say thank you to our funders, the NIHR School for Social Care Research. And here is the disclaimer, just that the views expressed in this presentation are those of the authors and the research team and not necessarily shared by either the DHSC, the NIHR, the NHS, or its arm's length bodies. I just also should say I talk quite fast, and I'm sorry because I realize that on especially this kind of medium, it may be even harder to kind of follow through, but I'm going to try and really stop myself from doing that. But if I run through the first early slides, it's really just to kind of get to the part about the findings as quickly as possible, because that's what I think the most interesting bit. But I can't not tell you about the background to the study, just to kind of contextualize it. I'm sure lots of you over here will know all of this literature anyway, but just to start with saying that moving to a care home can obviously be a really difficult decision for some people with dementia and their carers. And we started with looking at the literature and realizing that a lot of studies indicate that people with dementia are often not included in these decisions. So we were really curious about how these transitions are made by people with dementia. When do they decide to move to a care home, and what might be the factors and drivers in these decisions? People with dementia not being included in the decision also seem to indicate that they might negatively affect their ability to settle into the care home. So we really wanted to kind of unpick what these transitions were like and how these decisions were being made and at what time. Determining when and if any was an optimal time was something we wanted to kind of capture. And a lot of studies have, again, focused on the views of people with dementia and carers, but not a lot has been done about what the views might be of social care practitioners or those who may have decision-making authority or advice to give around these issues. So principally, this presentation is going to focus on the views of social workers and care home managers in relation to what they think might be an optimal time for people with dementia to move into a care home. So we designed this three-part study, which was funded by the NIHR School for Social Care Research, that looked at essentially what might be factors that affect the decision to move, who may be drivers of this decision, and ultimately what may be considered, if any, an optimal time for people with dementia to move. Like I said, in this 20-minute presentation, I won't be able to cover all of the participant groups or everything we did in a 3-year study, but I hope to be able to kind of direct you to where you might get more information, as well as I'm very, very happy to be contacted for anything more you would like to unpick. So the first part of our study was a systematic review. We completed this in 2018, and here's a reference for it that looked at specifically, is there an optimal time to move to a care home? But in terms of what we did for the longer term study was essentially face-to-face one-off qualitative interviews. We conducted this with a range of participants. We obviously had obtained relevant ethical permissions, and we had significant input from our really valuable study advisory group, who kind of indicated what might be useful questions to ask and what might be good interview topic guides to develop. So we did this with them. We got permission from the ethics bodies, and we conducted face-to-face one-off interviews with a range of people. For purposes of analysis, we got interview recordings transcribed, and we used a really straightforward system of thematic analysis, which is essentially just looking for repeated patterns in transcribed interviews and kind of collating this to make a cohesive story from what is in the data. For purposes of this presentation, I'm really going to be talking to you about the people we spoke to who have the authority to make decisions for people with dementia and family carers, but also who very much supported people living with dementia and family carers to make the transition to a care home move. So we spoke to 20 social workers. There were only 2 men in the sample. They were quite diverse ethnically, but 5 of them worked in hospitals. We spoke to 20 care home managers, again, from a wide range of care homes all across England. 4 of them only were men, and most were predominantly white British. So now I'm hoping to slow down and really talk to you about the findings from our study. So we had essentially 40 transcripts, and like I said, we went through them thematically to try and kind of get a sense of what the themes in the data may be and what may be trends or stories that may be patterns emerging in the data. I'm going to talk to you about each participant group first and share a little quote that kind of typifies the experience. And then I'm going to just give you a few concluding comments at the end, and finally end with what the COVID context may be, just to kind of share with you what brief reflections they may, just to kind of situate the fact that, you know, it's happening. COVID is very much happening, and care home moves have been so disproportionately affected. So in terms of our interviews with social workers, we asked them about what were the indicators they used to advise people with dementia and carers about making these decisions. And many of them said that one of the predominant themes was that they prioritized risk and safety as an overriding principle. And they kind of viewed whether or not the family carers who were living with the person with dementia continued to have the ability to look after their relative in a safe manner. So this, they said, was one of the predominant ways they kind of made a decision whether or not to advise someone to consider a care home move. However, underlying all of this, they firmly believed that the wishes of the person with dementia were very important. So they constantly kind of weighed these up with what were risk and safety issues, but what were the wishes of the person with dementia as well, and tried to find this balance for a family on a very individual basis. Acting in the best interest of the person with dementia was often necessary. And a couple of times they talked about how it was necessary to maybe even override their wishes if it seemed like the person living with dementia did not want to move, but in the best interest of them and their carer and their safety, they needed to. And it was amazing how many of them said that almost all of them had positive outcomes. So even if it seemed like the person living with dementia did not want to move to a care home, and overriding their wishes seemed quite contrary to how they wanted to operate, it almost always resulted in a positive outcome, and using a best interest principle actually always worked in their favor. So just this one little quote where the social worker says, so it's kind of constantly weighing up and looking at the risk, I think, and weighing it up. Is that a risk that we would be willing to take? Is there something we can do to prevent that risk if we get them back from, say, a hospital? But we have to kind of rule out everything. It's only then we would suggest that maybe a move to a care home would be the better option. So many of them talked about it like a last resort, but only after they considered other elements, not because it was the worst possible outcome, just because they wanted to kind of suggest what other things there were before they suggested a care home. Findings from care home managers indicated that many of them felt that an early move was beneficial to them in the care home as well as care staff, so that they could get to know the individual with dementia better, get to know their likes and dislikes better, and what their preferences were, rather than just have to go on what might be the carers, the family relative, the family carers indications about this. However, they again were very aware that the needs needed to be balanced against most older people's wishes to stay in their own homes for as long as possible. A really interesting finding was care home managers said that paving the path or getting people to talk about these things was useful, and many suggested that respite suggested by social workers as a stepping stone towards a permanent move was a really useful way of looking at a care home move as an eventuality. And it's really useful because it's a study we have since got additional funding from the Alzheimer's Society, looking at respite care and how this can be a potential stepping stone towards a permanent care home move. And many care home managers also said using a waiting list was also a really good way to get people to think about preparing for a permanent move and to get them to talk about it. So a lot of people say talk about these things early, get people to talk about what preferences are. But these were really clear indications of thinking of a waiting list, thinking of a respite move as clear indications on that journey towards a final move to a care home. So this care home manager says, at least start the ball rolling and build up a relationship with a care home that you would really want to move into. I absolutely welcome people if they wanted to come and put their names down on the waiting list, if they just want to come and have lunch once a week or something, and just sort of take part in a little bit of the care home. I wouldn't have an issue with that. I think it's a really nice way of sort of introducing them to the home and how the home works. And I know there's a little bit of research right now about how a care home can be a part of the community rather than these institutions very much on the fringes of our lives. But this was a really good way of getting people to talk about it early on in itself, early on in the diagnosis of dementia, but early on in everyone's lives if it's something that people want to eventually consider. Is there an optimal time? Again, I mean, it was really highly subjective. Lots of people talked about it being very complex, a personal decision, but really quite subjective and a really hard balance for practitioners felt to strike because there were so many different things to weigh up. And it all depended on when the person with dementia or relative was ready or when they realized that they could no longer cope at home. We wanted to kind of weigh up just a couple of slides about weighing up whether or not moving in early is better than moving in during the later stages of the dementia journey. And the social worker says the person with dementia being able to take part in the decision-making process is actually a really beneficial thing for them to do. So moving in early has those benefits because it gives them the opportunity to adapt into a care home environment. And they do sometimes. And that actually is a really beneficial thing for obviously the person living with dementia, but also the carer and the care staff and the care environment in itself. However, this social worker was a little more skeptical about whether or not moving in later was actually beneficial because they felt that limited awareness may be beneficial in maybe potentially minimizing distress, but also talked about the care home environment potentially being de-skilling for some older people with dementia who may potentially be able to manage and not need to be in a care home at that stage. So this one says moving in too early, you are potentially de-skilling someone. A lot of homes, they do the things for you. You're in a 24-hour living environment where they get you up at a certain time, they make tea for you, they make lunch for you. You don't really have that independence. There was the theme about the impact of finances on optimal time. And it was quite obvious that social workers and care home managers often provided information and advice about England's system of means testing in social care to families. And one of them talks about, I think people are a lot more aware these days that social care isn't free and they're going to be financially assessed. And savings are expected to pay for their own care. But understandably, people do get very upset about that and feel that it's very unfair. Overall, though, there was no consensus on optimal time. Lots of people felt like it was so subjective and so personal that there was no moving in before is good for some people or moving in later is not. It really was a very, very personal decision based on family dynamics. It was very obvious that the care home managers provided a substantial amount of support, both information and emotional. And I go on to say a little bit more about this because this was something that we felt quite strongly about because we felt like care home managers were doing so much more than is usually acknowledged or recognized. And especially to those who are self-funding, we felt like a lot of people who were funding their own care had nowhere to turn because social workers could potentially not help them. And care home managers were doing a lot of the support and advice giving, and especially emotional support as well when a relative had moved into a care home. And we felt that cost shouldn't include need or timing, but it certainly seemed to affect choice because if people weren't self-funding their own care, they didn't have the choice of where they could move to, and even if timing was in their control, the options were a little bit more limited if they weren't funding their own care. And finally, I just want to say a couple of points about the COVID context. These are really just relevant research questions that we are curious about in terms of now that things have changed. We wonder whether the nature of decision-making has changed. And we sometimes think maybe it hasn't. Maybe a lot of the decision-making is very much the same, where you're still weighing up the risks and the benefits. People will still be weighing up whether or not it's a good time or a bad time based on the same indications. However, obviously things have changed in relation to care homes as environments have changed and people's notions of what the care home environment is like has changed. So people may be using slightly different indicators when they're weighing it up, although risk and being able to manage at home will still very much remain the same. I just want to also talk about this notion of settling in, because it came up as a big theme in our interviews with people living with dementia and carers. And we have since had anecdotal evidence from some people living with dementia who moved into care homes that it's been a far less straightforward move. People have been asked to not be able to, family has been asked not to visit their relative once they moved into a care home. And it's a very much more upsetting way of settling in someone. And there are associated impacts with people living with dementia who may not settle in the way they had before. So we are curious about whether we should be unpicking a little bit more of what settledness into a care home means and how this can be done better, what the role may be of care staff and care home managers in helping someone whose family can't visit once they have moved in, and how that can be kind of managed a little bit better. Obviously, the pervasive sense of uncertainty is probably even more exacerbated in care homes. Will the care home survive? Will care home, what will care home markets look like? Will care home staff remain the same? Will there be higher turnovers? Will there be agency staff being employed? Obviously, the pervasive uncertainty in these care home contexts is exacerbated. And we feel very much that care home managers may be kind of coping with a lot more, while also kind of weighing up when a relative with dementia wants their relative, when a person living with dementia wants to move into a care home. And finally, just a final couple of points where there are large generalizations persisting in the care home sector. A lot of it has been underpinned by the media accounts recently of separation and the dramatic narratives about how awful these separations have been. And while these are traumatic and really, really deeply emotional, it may overlook a lot of people who may still be in care homes without family visiting them and be even more cooped up and isolated since COVID has hit. And we kind of wonder how their moves have been managed when there are no relatives to actually even settle them in or take them to the care home, and what happens to a lot of these older people who have no support structures with or without COVID. And finally, I think this is a good point to end on, where I just, again, like I said before, we feel very strongly that the role of care home managers has probably not been considered as deeply or as strongly as they should be. We found in our interviews that they were very, very supportive of all the residents who were moving in, of the family carers who contacted them for support, of the care home staff. And we feel like as a role of the managers, they've been probably even managing more as a result of COVID, managing all of the, not just PPE and all of the safety issues, but also just the emotional stresses and the uncertainty that must be prevalent in these care home sectors. And we feel like it's a group that we should be researching more with, and we would urge research communities to kind of include them more in a lot of our social care research, because we feel it's a social care jigsaw, or the social care workforce jigsaw piece that potentially gets left out in a lot of our research otherwise. And I'm going to just end there with a link to our final report and the paper that's just been published based on, that covers a lot of the stuff that has been mentioned in this presentation, but I'm also very happy to be contacted, as I'm sure any of my colleagues. Thank you.
Thank you very much, Kritika. That was a very interesting presentation. We've got 84, I think, participants in this webinar. So whether people want to ask any questions now, there's an opportunity. There are no questions in the chat so far. So does anybody want to raise a hand to ask a question? Martin, go first.
Thank you, Kritika. That was really good. I just saw a tweet about an hour ago with an abstract to a paper that Clarissa Giebel and colleagues have produced about admission into care homes. I haven't read the full paper. I haven't even read the abstract, but they talk about socioeconomic differences in patterns of admission of people with dementia into care homes. This is based on data in Wales. So what do you think about that? I mean, is that something that came through in your research, those differences in the characteristics of the individuals themselves?
No, we didn't have a lot of differences in characteristics. We did have in terms of funding, and that was a big one, where people were either self-funding their own care or dependent on local authority funding. And that was a big theme where a lot of people, it wasn't one of the focus points of our study, but it was one of the things which came up about a lot of people didn't know how long finances would run on for. And it was something that they were getting to be more aware of, but it was something they felt they were very much at the mercy of the care home manager guiding them. If they were self-funding, if they weren't, they would just turn to the social worker. So we didn't kind of get socioeconomic differences or any other big differences except this big funding issue and not knowing who to turn to for more specific information about it.
Thanks, Kritika. We've got a couple of questions in the chat and a comment from Karen Littleford that it's great to see the role of care home managers better recognised, especially the emotional support they provide. But the questions are from Joe Fitzpatrick, a really important study. Did you include the perspectives of residents? And from Wendy, how did you access the participants?
So we did include the perspectives of residents. I didn't present it in this just because it was more participants and more data. We interviewed 20 carers, and we wanted to interview people living with dementia in their care homes. And our ethics only allowed us to interview those who had capacity to consent. So that is something we would do differently, where we did find that many people who had moved into a care home did not have capacity to consent. So we only interviewed 5 people with dementia, which was incredibly rich and incredibly valuable, but it's not something that it's something we would do differently to include more.
Thank you. And
how do we access the participants? We contacted care home managers that we knew. We sent out flyers. We advertised the study widely. We didn't at that time use joint dementia research, which again, I think in hindsight we would, and nor was CRNs helping with social care research, which I know they are. So again, this was a study that finished last year, so we conducted a lot longer ago. So I think there are little things we would do differently to get maybe a different data set, maybe, but also a wider data set potentially.
And I've got somebody, I've only got the first name, Amanda, commenting that carers often struggle on far too long to keep their loved one at home, by which time they've lost capacity.
Yes, and very much agree with that. I think like a lot of people, it was ironic because a lot of people did talk about care homes as being the last resort, but everyone who had done that did not feel that once it had happened. They felt like care homes were actually wonderful environments for their relative with dementia. It may not be for everyone, but this care home as a last resort is some stigmatized view that may not be appropriate, because there are lots of people who have found it a useful move, have found it's actually been beneficial for their relative with dementia, for family dynamics, for family carers. So we do think that actually leaving it till the last moment or the last option may not be the narrative we always want to kind of talk about. And this study kind of really showed us that.
And Sandra Duggan asked, what about the effect of lack of appropriate domiciliary care?
Yeah, again, yes, you're right. Because we interviewed social workers and care home managers, there was a little less of that because they thought that they had exhausted all their options before they recommended a care home move. So from the perspective of the participants we included, there was a little bit about the lack of appropriate domiciliary care, but it was really like they had exhausted all their options before they suggested the care home move.
And finally, I think because of time, Fawn Harrod saying, apart from agreeing with Karen, wondering whether there are any differences between different types of carers. Was your study large enough to pick those up?
No. Did you mean care workers? Not specifically, no. No. Between, you mean social workers and things? No, not specifically.
No, between sort of parents or children caring for.
Again, I haven't covered it in this presentation, and that will be the focus of another if I can, just because it would be a larger data set. So there were differences between the family dynamics and things, but I can maybe talk to you separately because, like I said, that would take a little bit longer. I'm happy to reply to anyone in the chat after, but I realize in the interest of time, I shouldn't go on for too much longer.
I think we might have time to squeeze these couple of last 2 quick ones in. Oh, they're coming in fast now, so it will only be just these 2. How did you measure the outcomes?
We didn't measure them. We really just asked them about the outcomes. So maybe outcomes is the wrong word. It was really just asking them, and they said that the person had settled in, the family was happier, the relative with dementia, the relative living with dementia had said they were happier, settled in, and they were settled as it were. We didn't actually measure it. It was a purely qualitative study. Okay,
that was Jolie Keeming. And Kelly Lee wants to know whether you found many people who'd moved into a care home permanently who didn't know that they'd been.
Again, it's another important point because we also found that no one, the move to a care home wasn't a simple deciding to move, there were lots of like little transitions along the way, either from hospital to a care home, from one care home to another, from, there were lots of, no one ever moved in and never moved out again. Or, I mean, I'm sure there were, it's just that it didn't happen so straightforward for everyone. So it's a good point that there may be people who hadn't been told they had moved in permanently, but we found that it never was a permanent move, if that makes sense. It was these trajectories where people moved in or went to the hospital, came back, moved into another care home, and before there was a final move, if that makes sense.
Okay. Kritika, thank you so much. And thank you for you put us back on track for time as well. So that's great. So I'd like now to, and you will get back to any other points on the chat if you can.
Yes.
So I'd like to introduce Anne-Marie Towers from the University of Kent, who's going to talk us about regulator quality ratings and care home residents' quality of life. Anne-Marie, are you able to share your screen?
I hope so. Can you see that okay?
Yep.
Okay, lovely. Thank you, Kritika. I thought that was a really interesting presentation. I saw the early findings of your study, I think when you presented at another conference, so it was really nice to hear the end of that. So I'm here today to talk about regulator quality ratings and care home residents' quality of life. I just want to acknowledge my co-author on this presentation, Florian Vadian, who's also dialed in for this today, and Florian ran the OLS models that I'll be talking about a little bit later on. So I'm actually going to be talking about data from two studies. The first one was a SSCR funded project, the Measuring Outcomes of Care Home Study, or MOOCH for short. This one was between 2015 and 2018, and I've given you a link there to a publication relevant to what I'm talking about today. And as you can see, that was a paper about regulator quality ratings and care home residents' quality of life. But what I'm going to be doing today is talking about new analysis that merges that data set with this additional new data set. And this is the Measuring and Improving Care Home Quality Study, or MyCare. And that project was funded by Health Services and Delivery Research, and that only just completed in August of this year. So these findings are hot off the press. I can't give you a link to a final report because it's still in peer review. So I've given you a link instead to the protocol. But obviously papers will be coming out from this. I'm not going to read all the names out, but just to acknowledge the wider teams involved in both of these projects, because I think that's really important, and to draw your attention to the fact that this was University of Kent and also Brighton and Sussex Medical School for the second project. Okay, so what are our research questions? Well, the work that I'm talking about today, we asked two main principal research questions. The first being, are CQC quality ratings associated with care home residents' social care rated quality of life? And we're talking about both the overall quality ratings, but also those key lines of inquiry. And secondly, does this vary according to the needs of the residents? So, for example, compared with residents with relatively low care needs, so residents with high care needs benefit more from homes with better quality ratings. So I'm not going to spend too much detail on the methods, because obviously you can come back to us if you're interested, or you can read that paper that I gave you, because both studies broadly use the same methods. We had a cross-sectional design for both studies. The first part of data collection involved questionnaires being completed by care staff about residents' needs and characteristics. So this will be things such as activities of daily living, demographic information, cognitive impairment, diagnosis of dementia, and so on. We also then went into the homes as researchers and collected data ourselves about resident social care and quality of life using the ASCOT tool. Those of you who aren't familiar with ASCOT, I haven't got time to give a big overview today, but just to say that the care homes tool is inclusive. It uses a mixed methods approach that enables us to include people with dementia and also include people who, for whatever reason, cannot self-report. So for that reason, we're able to capture quite a significant proportion of the care home population. We also noted down and recorded for the data set the quality ratings made by CQC that were closest in date to our data collection. I'm not going to dwell on this, but just to say that we obviously did have ethics and governance approval from local authorities, and for each study there I've given you the reference number. And of course, we also got approval from the Association of Directors of Social Services. So let's get into the interesting bit. So we had 54 homes across the two samples from 4 local authorities in the southeast of England. 30 of those were nursing homes and 24 were residential. Our homes varied in size, as you can see, between 10 and 120 beds. As you would expect, if you're familiar with our system in England, the larger homes tend to be nursing homes. Our mean size was 49 beds, which is actually a bit closer to the mean size of nursing homes as opposed to residential homes in this country. 47 homes, so the majority, were in the private sector and only 7 were from the voluntary sector. And actually, if you're familiar with the balance of sector in this country, you'll know that for England, that's pretty much there or thereabouts the national picture. The only exception being we didn't have any local authority homes, and there's only very relatively few anywhere across the country. The mean weekly fee was £817 a week, which again is closer probably to the mean weekly fee you'd expect in a nursing home, although the range is significant, as you would expect. So thinking about our resident sample characteristics, 2/3 of our sample were female, as you would expect, and the mean age was around 84 years old. Around half were self-funded, and by that we mean either completely self-funded or they were at least topping up local authority payments, so they were funding some of their own care at least. On average, our residents could do roughly 3 activities of daily living independently without help, which is obviously quite a low number, but similar to what you would expect in a care home. Around half had dementia, and the mean level of social care as a quality of life, which is the ASCOT score, was 0.75. Now, I'm aware that not everyone will know what that means, so just to give you a bit of context, the highest score possible if you scored ideal quality of life in all the ASCOT domains would be a 1. The general population, when we surveyed them a few years back, were getting around 0.86. So this is typical of what we tend to see in care homes, a 0.7 something score on average across residents. So the quality ratings of our homes. So the overall CQC quality ratings, as you can see, around 2/3 were rated as good. Slightly over compared to the national population, we had 9% outstanding. The national figure is slightly lower, but as you'd expect, better homes take part in research. And only 25% requires improvement, but that is pretty typical of the national picture. We didn't get any rated inadequate, and I can talk a bit about that later at the end if you're interested. Good and outstanding homes, because we had such a small number of outstanding, were merged into one category. So when I talk about the modelling later on, we're talking about basically a binary variable there. So requires improvement versus good and outstanding. If you look now at the key lines of inquiry, what you can see is that overall, homes were rated good, as you would expect, in most of those key lines of inquiry. However, there was the greatest need or greatest room for improvement for safety and well led. And caring was the key line of inquiry that homes did the best on. So let's come back to our question. Do people living in outstanding and good homes have better social care related quality of life than people in homes rated requiring improvement? So our OLS estimation results were run for 5 different models. I'm not going to go into the details of each one, but I'm just going to give you the main findings for today. So the first model that we did, model A, was basically a replication of the Mooch findings, so that paper that I cited at the beginning. And here for Mooch, we found the following significant results. That there was a positive relationship between residents' quality of life and being in a good outstanding home. In other words, all other things controlled for, residents living in homes rated as good or outstanding had a better quality of life than residents in homes requiring improvements. That's what we'd already kind of established in the previous paper. We also, in the previous work, and we replicated it here, found that there was a positive relationship between females, so you're slightly better off if you're a woman, and you were slightly better off if you could perform more activities of daily living. And we also found that you were slightly worse off if you had a cognitive impairment. Now, the other models that we looked at for this analysis, we found several interesting things that I'm going to draw out today. The first one was that the ASCOT measure for expected social care quality of life, which is effectively what that means is what the person's quality of life would be in the absence of services if they didn't have that care and support from the care home. We found that that as an indicator was more sensitive at capturing people's social care needs than ADLs and cognitive impairment were. So that's just something to think about when we're doing this modelling in the future. We also found, interestingly, that there was no evidence that self-funders get better outcomes than publicly funded residents. I think that's quite interesting for several reasons. We know that self-funders often pay more than publicly funded residents. And so we wondered, is there any evidence that they're effectively purchasing better quality care with their additional money? It's good in many ways that they aren't for publicly funded residents, but it also makes you query value for money for those self-funders because they aren't clearly gaining anything in terms of social care quality of life at least. We also found, and this is really important, I think, is that out of residents with high care needs versus residents with lower care needs, when we compared the two, it was actually the high needs residents who showed the greatest capacity to benefit from those better quality homes. So if you look here at an example, we take a resident with high care needs and they lived in a home that was rated as requiring improvement. If that home became rated good or outstanding, we would expect that person's social care quality of life to increase by 0.09. So if they started with a mean score of 0.75, as we said the mean was in care homes, this would go up to 0.84 for social care quality of life if the home was rated good or outstanding. And that's the equivalent to a 12% increase when you look at the average quality of life of the sample. So although we're talking about what looks like very small numbers, you've got to remember that that social care quality of life scale is small. It's on that, effectively 0 to 1 scale. So that's a meaningful thing, that high needs residents benefit more from that improvement in quality. So we wanted to unpick this a bit by looking at key lines of inquiry. So remember these 5 lines of key lines of inquiry are safe, effective, caring, responsive and well led. And what we found was that it was caring and well led that were most related to social care quality of life. The caring key line of inquiry talks about residents being treated with compassion, kindness, dignity and respect. And when we unpicked this a little bit in the analysis and we looked at the ASCOT and the different domains of ASCOT, what we found is that caring was particularly strongly related to the ASCOT higher order domains, which are social participation, occupation, so how a person spends their time, so being engaged in meaningful activities, having control over their daily life, and dignity, so being treated with dignity and respect. And so being rated good or outstanding for caring will lead to significant improvement in those aspects of the person's social care quality of life. Then when we look at high needs residents, what we found was that particularly important to high needs residents was that the care home was rated good or outstanding for being well led. So this is a really interesting one. And again, we've tried to unpick this and look at this a bit more detail. And what we think might be happening here is that when a care home is rated good or outstanding for being well led, then it is actually a well managed home. And perhaps the staff are given, for example, a good working environment, their skill set is kept up to date and supported, and maybe things like staff are given the time that they need to spend with residents to lead to better improvements for higher need residents. This is a bit of a hypothesis, but just looking at the data and trying to look at those key lines of inquiry in more detail and what CQC look at when they measure those, we think that that might be partly what's going on in the background there. Okay, so I could talk about this all day, but I won't, because I think it's more important that you get time to ask questions. So just to say that in terms of limitations for this data, the analysis was restricted to homes in the southeast of England, although we have tried our best to get a representative sample. And just to note that we do think we had a slightly higher number of self-funders, particularly for the MyCare study, than what would be typical in this population. Okay, I'm going to try and stop my screen share. Okay, hopefully I'm not sharing anymore. Is that all right?
Marie, thank you very much. And we've got a good amount of time for questions now. So again, does anybody want to kick off? Either put a hand up or put something in the chat. There are faces on 4 screens, so it's a bit difficult to scan all these. Hang on a minute. No.
I can see one in
On the chat?
Yeah.
Okay. So Sandra Duggan asked about the point about negative relationships with CI.
Oh, so cognitive impairment. So residents who have higher levels of cognitive impairment would have poorer social care related quality of life, all other things being equal. So even controlling for other factors like quality ratings of the home. So this week we can't really unpick in a lot of detail, other than that we see that if the person, for example, is less likely to be able to self-report, is less likely to be able to maybe communicate their needs and wishes, that we think that it does actually still have a slightly negative effect on their quality of life from what we can tell.
Thank you. And Liz Wansmurray's got a long question in the chat, which you might like to look at afterwards. But I think as I read, it's essentially saying that many care homes feel they have to deliver to the key lines of inquiry. And does this impede their ability actually to provide what's best for residents?
Okay, well, I mean, that's really interesting, but certainly most of our homes, if you looked at what came out as being significantly related to care home residents' quality of life, was being caring. And the homes seem to be doing that really well, actually, because there was most of them were rated good or outstanding for caring. And that one seemed to be particularly the thing that mattered the most. Some of our key lines of inquiry weren't related to these ASCOT, social care quality of life scores. And when we unpicked a little bit more about what those key lines of inquiry look at, they tend to be more around process outcomes, administrative things, and therefore we wouldn't necessarily expect them, although they're not saying they're not important, we wouldn't necessarily expect them to be picked up in a quality of life measure, for example. So how much difference they make to the quality of life of residents, we certainly didn't find that they were associated. Whereas the well-led one we did, caring certainly we did.
Thanks. Thanks, Anne-Marie. And Vesa Tosika's asking, when you talk about positive relationships between good, outstanding and quality of life, what approximately was the odds ratio?
Pass. I wouldn't know that without going back and looking at the data for you. Sorry.
It's available, that people be able to follow that up in the paper.
Yeah, absolutely. Yeah. I haven't got the technical numbers to hand. Sorry for that. I'll have to come back to you.
And Natalie Leworthy, Leeworthy, sorry if I've mangled your name, Natalie. Was there anything you could draw out about the gender differences for quality of life?
Well, we didn't look specifically at gender differences. We noticed that women, did score better. So you were lucky, if you're a woman, you did have a slightly significantly higher quality of life. But we haven't unpicked that, and partly also because we have such a large proportion female, we would have much lower numbers for men to unpick what was sitting behind that. But it's certainly something that I think is really interesting. And we know that care homes are a very female environment, and a lot of the staff are female. So I think it would be something that would be worthy of further research.
Anne-Marie, Derek King asked sorry if I missed it, but was the size of the care home adjusted in the modelling?
Yes, it was. It was controlled for, yeah.
And Karen Littleford is asking, having a culture of continuous learning and positive engagement with people using the service and others in their life is part of the manager's role. Was the importance of the manager's role in terms of people's experience in a care home very apparent in your research?
No, I suppose the short answer to that is that we didn't have a way of measuring that. So I suppose unlike Kritika's study, although we use some qualitative methods to collect the data, it's primarily quite a quantitative project in the end. So although care home managers are certainly important in letting us in the door, and we would notice we do notice care home culture when we're in there collecting this data. We're not systematically recording that culture or interviewing managers in their own right for the study. So it would probably be a little bit unfair of me to comment too much on that. Yeah.
You might want to take the fifth on the next question as well then, but Bersha Sue is asking whether you would say leadership will have a direct impact on other key areas of assessment.
Well, I mean, certainly if you look at the well-led key line of inquiry, which is looking specifically at that issue, then I would say there's certainly scope to say that it's impacting directly on those with the highest needs, which to me, I can only think the pathway for impact there is that being well led means that you're supporting your workforce and you're in creating a culture where people's needs are being met and everybody's needs are being met, even those who cannot speak for themselves. Because when we talk about residents with high needs, effectively what we're talking about is those are the most vulnerable residents, the ones who can't speak up and say, I want a cup of tea now, or I want to go and do this. Or so to meet those people's needs is harder work for services. So I think, you know, just the fact that we found that is really important, that was a really significant relationship for residents with higher levels of need. And I think, you know, although we haven't specifically unpicked that in this analysis, you know, I do a lot of work in care homes anyway. And, you know, I personally do feel that the leadership of the home matters enormously to the care culture. And certainly I know that a lot of staff, whether or not they're task focused or whether they're focused on outcomes and quality of life, will depend on the leadership of the home, because it's the leaders that determine the culture. So I can't, you know, I might not be able to answer directly from the findings, but I think it backs up what we feel about that. Yeah. Well,
it's like any good study, Anne-Marie, it generates lots of questions, and here's another one. Asking from Bridget Penhale, wondering whether you would be able to say anything about what you think the differences might have been had you included care homes across England or maybe even in Wales.
Oh, that's a really tough question, Bridget. I'm not sure really. I mean, I think one of the limitations that I noted when I talked about geographical region was also that I noted we had a lot of self-funders. And we looked at this actually in a little bit more detail, and we noticed that some of our, particularly 2 of our local authority regions had high numbers of self-funders. Remember, this is the southeast. So I do wonder whether that might make a slight difference. So if we were to go to areas of the country where there are more local authority funded and less self-funded, then there would be less income overall coming into the home, because we know that local authorities pay less than self-funders. What impact does that have on the resources that the home has? So that would be something that I would be interested to look at in more detail. But I'd be open to ideas really of what other people think would be potentially the differences.
Well, Liz Wans-Murray points out that there would be different regulations certainly across England and between England and Wales.
Yeah, if we were to go to other countries, you know, we're in the UK, and that would be.
And Fawn Harris wondering, as I am actually, did you have you shared these findings with the CQC, and how did they respond?
No, so these merged. So the paper is out and it's publicly available. We didn't get any particular interest from CQC, but no one's approached us or talked to us about that. These findings that are based on the larger sample are not publicly available. This is the first presentation of these. So as I said, that's the report based on the findings I've reported today is still in peer review. So it's early days yet, but it would be great to engage.
Any other questions? There are none in the chat. I can't see if anybody's got a hand up. Well, that gives us a few minutes for any questions that you might want to put to Kritika or Anne-Marie, if anybody has anything they'd like to ask. Martin.
Yeah, I mean, it's a question to both the presenters. Well, comment first of all, those are two amazing presentations. I can't imagine how you got through so much material in such a short space of time in very clear description. So thank you very much for that. But how do you think, I mean, I know you're both working now on COVID related studies. How has COVID affected, how would COVID have affected what you found?
Do you want to go first, Kritika?
You can.
Okay, well, do you mean found or do you mean actually collect the data? Because obviously we wouldn't have been able to collect the data. That would have been the major issue. Had luckily this study data collection finished in January, so really relieved about that.
I think so too. I think our data collection would have really been different because it's still quite a busy and stressful and emotionally difficult time. So something to talk about. And the few anecdotal evidence we've had because of our other studies has indicated that it's been a really traumatic, for want of any other word. The moves have been people literally leaving their relative on the doorstep and not being able to go in. So I think this kind of data would have just been very, very different, but may have kind of thrown up different ways to kind of support the care home workforce because COVID is here to stay, at least for the short term. So we may have kind of been able to unpick a bit more how care home managers could be better supported to support residents moving in without the usual processes.
I think also in terms of residents' quality of life, when we think about those higher order domains, social participation, control over daily life, engagement in meaningful activities, I mean, I don't know how homes would be sustaining that same level of quality of life in the absence of volunteers coming in, family members coming in, residents potentially being restricted to their bedrooms, or being attempts to socially distance within the homes. Because a lot of what we look at when we look at those aspects of quality of life, it's all around togetherness and friendship and homes do get a lot of people, well, good homes with lots of exciting things and meeting people's outcomes in these domains. They're vibrant environments, and I can only imagine that at the moment that's really difficult for homes to maintain. So I think we probably would see some differences if we were somehow able to collect the data if we were to go in now. Yeah.
Angie Mifta's got quite an interesting question, is a roundup question, which is, how did you find engaging the care homes, and have you discussed the findings with them? Question to both of you, I think.
Yeah, so we found engaging the care homes for the Mooch study relatively, actually very good. We didn't have any difficulty. I'm not really sure what the difference was, but we found it much more challenging for the second study, the MyCare study. I think partly because the Mooch study was closer to home, we were able to easily build relationships with homes as a team based largely in Kent, get to most care homes and back within a day, do multiple visits to establish rapport, all of that sort of thing. Whereas as soon as we expanded the sample size for the second study and we were going further afield, albeit still within the southeast, you're still talking about not being able to do that level of personal contact, because it just would become, the research costs of doing so would be prohibitively expensive. So I think, engagement was more difficult. And when we try and do these studies, and everyone wants us to do studies that are nationally representative on a bigger scale, these are some of the trade-offs that we do need to think about. And partnering with universities that can reach out to their local areas might be a good way of solving that.
And we had the same. We had very mixed. Some were really engaged and really engaged care home managers were happy to send out letters on our behalf, get in touch. Findings wise also, they were very, very engaged with receiving the findings, seeing what more they could do, but some were just not in the same way, either didn't have the capacity to be able to kind of take on whatever we required from them, or just weren't interested in the topic, not quite sure. Some really were and some really weren't. So I think it is just patchy, and maybe something that, like Anne-Marie said, is something we could potentially build on, just kind of making sure we have really good networks, but then it becomes the usual suspects taking part in all the research, which is not obviously helpful either. So just kind of managing that a little differently, I guess.
Kritika, thank you very much. And thank you for two fantastic presentations, very different, but really interesting. It's a rich seam of research, as demonstrated by the number of people who joined this webinar. I've got one notice from Fawn Harrod and one from the School for Social Care Research. Fawn is saying, just a reminder for anyone interested in conducting care home research to think of contacting the local Enrich team. And the School of Social Care Research wants me to remind you that the next webinar is on the 27th of October, and that will be focusing on research about carers. So another very topical and interesting webinar. And thank you very much for organising them. They're really interesting. And it's been a pleasure chairing this one. So thank you very much for everyone. Oh, somebody asked, will the presentations be available? Could the PowerPoints be available to participants? I don't know what your...
Yes, they will. They'll go onto the website and we'll send the link out.
Perfect. Okay.
Thanks for having us.
Bye. Nice to see you. And thanks again to speakers. Bye.
Bye. Bye.